I'd like to thank the Taxol Foundation for giving us this opportunity. As Gary said, rare cancer is major challenge, and we don't have the opportunity really to get together like this. Get the patients, the researchers, the clinicians, scientists studying rare cancers. We don't get put in the same room very often. And every time I've done it, for instance, I was involved with a DoD, a rare cancer research program. But every time we all get together, I think we learn from each other. One of the other challenges with rare cancers is that, obviously one rare cancer is different than another, but the way that we have to address those are different also, right? Different rare cancers affect different socioeconomic patient groups or different racial ethnic groups. And that poses different challenges. And so I think we really need to learn from each other. So what I'm going to do is talk about rare forms of melanoma. But what I want to focus on is not so much on the science, but from kind of lessons learned that may be applicable to other rare diseases. There we go. There are my disclosures. And so just in the way of background, when we think of melanoma, it's rising in incidence, nearly 100,000 cases a year in the United States. Most of the time when we talk about melanoma, people think of skin melanoma, which, although it's a UV-associated disease, it most frequently occurs in sun-protected areas, the chest, the back, thighs. And so that's, about 80% of cases. But there are less common cutaneous melanomas as well, including what we call melanoma arising from sun-damaged skin, head and neck, back of the hands. It tends to happen in older individuals, golfers, people are outside a lot. And it turns out the biology of that is a little bit different than the more common melanomas. But then when we're talking about really the rarer subtypes, acral is a type of cutaneous melanoma, but markedly different. Acral melanoma arises from the palms of the hands, soles of the feet, under the fingernails. Really a rare type of melanoma. And then we get the extracutaneous melanomas. Melanomas that arise from the eye, melanomas that arise from the mucous membranes of the body, sinonasal region, mouth, anorectal region, vulvovaginal. And so when we think of melanoma, it's really a spectrum of different clinical diseases. In terms of demographics, this just kind of highlights some of the differences. And I've just highlighted some of the key points in red. If we look at cutaneous, acral, mucosal, and uveal, the mucosal melanoma patients tend to be a little bit older. You can see some differences in gender, where for typical cutaneous melanoma, it's a little bit more common in males. Mucosal melanoma is a little bit more common in females. And then you see the incidence, right? And this is where we get to the rarity. I would say acral, mucosal, and uveal all rare. There's a relative difference, right? So uveals will see 5 to 6 per million. We'll say there may be 2,000, 3,000 cases a year in the United States, pretty uncommon. But then you look at mucosal, which even is, more of a rare disease, and there we're talking 1 to maybe 3 per million, right? So distinct kind of epidemiology. If you look at race and ethnicity, if you look at the highlighted red, and these are all from different data sources, so that's why the numbers don't really add up. But cutaneous melanoma, it's a disease of, Caucasians, really. We don't really see it very frequently in, the Black, Asian, Hispanic population. Whereas if you look at acral melanoma, mucosal melanoma, these are more common in the African patient population or the Asian population, right? So when we think about patient education, outreach, and so forth, we're really talking about different kind of patient groups. As Gary said, one of the other challenges is that, for instance, mucosal melanoma, that's a rare disease. But even that rare disease is kind of a family of rare diseases. And we think of mucosal melanoma from the mouth, the oral cavity, that behaves very differently than mucosal melanoma arising from the anorectal region or mucosal melanoma arising from the vulvovaginal region. So imagine that. Vulvovaginal mucosal melanoma makes up about 20% of these melanomas. So maybe we see 300 cases a year in the United States. How are we supposed to study that, right? It's really challenging. So outcomes for all of these rare subtypes of melanoma, they're just worse than what we've seen for cutaneous melanoma. And just to highlight that on the left, the acral melanoma panel there, this was a study we did at Memorial. We just looked at patients with acral melanoma and then matched them for clinical characteristics and stage with non-acral cutaneous melanoma. And you can see the curves there. The yellow curve is the acral melanoma outcomes are worse. If you look at the mucosal melanoma patients in the middle panel, and this is kind of highlighted in that green, if you look at the 5-year disease-specific survival, it's about 25%, right? And you compare that with the orange bar, which is our stage 3 and stage 4 cutaneous melanomas, right? Mucosal melanoma even does worse from the time of diagnosis, irrespective of stage, right, than our kind of advanced stage cutaneous melanomas. And then uveal melanoma, this was a meta-analysis we did of about 1,000 patients showing that, you know, while median survival for cutaneous melanoma, we don't even reach it anymore, you know? I mean, our drugs, the advances we've made are so good, and here our median survival, at least at the time of this publication, was under a year, okay? So that just highlights that our patients with rare melanomas, they just do worse than our patients with cutaneous melanoma. Now, part of that is because of drug development. If you look at the number of drugs that have been developed for cutaneous melanoma in 2022, we've got 16 approved drugs or regimens. And the most recent one was just approved in March with relatlimab, right? That's really remarkable. And that's associated with the improved outcomes and the cures we're seeing in cutaneous melanoma. On the other hand, if you look at what we've done for acral, mucosal, we've got nothing approved for those subtypes. And for uveal, we just got the first drug approved, tebentafusp, in January of this year. So the hope is that, you know, if we focus on these rare melanomas, understand the biology, make meaningful efforts at drug development, we can do what we did for cutaneous melanoma. It's just harder. When we look at the way that drugs are developed in melanoma, you know, we do these trials, big randomized trials, primarily cutaneous melanoma patients, right? That's just the nature of how these studies are done. But many of these trials, and this is just for relatlimab, the new drug that was approved for cutaneous, you can see relatlimab, for instance, the trial, it excluded patients with uveal melanoma, right? So what does that mean? You know, we spent years developing these LAG-3 antibodies. We show that it works in cutaneous melanoma. I have no idea what it does in uveal. You know, patients with brain metastases, leptomeningeal disease, they were excluded. I have no idea what it does in those patient populations. And what does that mean? It means now that it's approved, now we can do trials in uveal, but we're 5 years behind, right? And so we do have an ongoing trial for uveal melanoma with this drug. It's great. We're working on trials for patients with brain metastasis. That's great. But imagine if we had included some of those patients in this early trial, even just as an exploratory subset, just to get a hint, you know, is there something there? Is this worth pursuing? You know, maybe it would have kind of facilitated drug development. And so some key messages from this first part is rare melanomas associated with inferior outcomes. 2, rare melanomas do arise in distinct demographic populations, okay, and that affects how we think about disease, how we educate patients, and so forth. And then rare melanoma subtypes are frequently excluded from melanoma trials. And so in red, I'm going to have these kind of red, kind of what I say, recommendations, which maybe are more broadly applicable to other rare cancers. That, you know, I do think that signals of activity or lack of activity could be obtained if we include rare cancer patient populations in some of these larger trials. So just something to think about. So in addition to the clinical heterogeneity of melanomas, there's genomic biologic heterogeneity. And this is a nice paper from the Australian group that did whole genome sequencing of, you know, a bunch of melanomas. So this is 183 samples, but if you look at the breakdown in red, the vast majority of these are cutaneous. They had 35 acral melanoma samples and 8 mucosal samples, right? And this was, you know, a major Nature paper, right? So we get huge papers with small numbers of kind of small n's of these rare cancers. But what they learned is that if you look at the number of mutations in these rare melanomas, which is that kind of the graph up top, you see there are a lot of bars, a lot of mutations in cutaneous melanoma, very few in acral, very few in mucosal. On the lower panel, you see you're just looking at structural variations or chromosomal changes. You can see there are more of those in the rare melanomas compared to the skin melanomas. So, you know, biological heterogeneity, and this is consistent with prior data sets. The reason why I show this slide is, again, all of these papers, you know, major advances in the field, but look at the ends, you know, that first Fernie paper, you know, important paper, you know, 10 mucosal melanoma samples. The Acral paper is based off of 5. the Uveal paper is based off of 12. And so I say this because one of the challenges is in the rare cancer field is obtaining, sufficient numbers of biospecimens, right? So we're learning a lot from small numbers, but I think we can learn more with greater numbers. In the uveal melanoma field, we were lucky that uveal melanoma was selected as one of the 10 rare cancer projects in the TCGA. And the TCGA, as everyone knows here, I think is just the big national effort for global molecular profiling in cancers. And so uveal melanoma was selected, national effort, 80 primary uveal melanomas were sampled, and this is obviously complicated, but what came out of this was a nice framework dividing uveal melanoma into different biological subgroups. One subgroup was those with 2 copies of chromosome 3 versus 1 copy of chromosome 3, biologically different. If you look at the copy numbers, there's a range of copy number alterations going from top to bottom, which was associated with prognosis. And then there are different kind of molecular programs that are associated with these 4 different subgroups, okay? I don't show the slide to really go through the data, but to get uveal melanoma involved or selected as part of the TCGA program, that took a lot of advocacy work. And I think one of the larger patient advocacy groups in ocular melanoma is through the Melanoma Research Foundation. And that group did a lot of lobbying to get uveal melanoma selected to get that national investment in this disease. And I say that, this is an event sponsored by an important foundation. I think the work that these foundations do is really critical. We need this sort of advocacy. We need the patient voice to help us make these advances. So you heard a bit about precision oncology and how rare cancers can serve as a model for precision medicine. And that's, we've certainly done that with melanoma, right? So we've done these broad molecular, whole genome sequencing studies. But from that large data set, we've pulled out what we call clinically actionable findings. And that's a little bit more simple, right? And what you see in these pie charts are some of the more common clinically actionable, that is, alterations that we can treat or ones that we're trying to treat. And you can see that the pie charts are different, right? Just highlighting that heterogeneity, cutaneous, acral, mucosal, and uveal. And we say that, melanoma is one that's frequently driven by BRAF mutations. That's true, but that's really true primarily for cutaneous melanoma, where about half of those are driven by activating BRAF mutations. Those activating BRAF mutations, which are targetable with pills targeting that MAP kinase pathway, they're less common in acral. They're less common in mucosal melanoma. And we don't really find them in uveal melanoma, which is totally molecularly different. Occasionally we'll find these TRK fusions, which are actionable. But what I've highlighted here is that melanomas like mucosal melanoma have a slightly higher prevalence of these mutations in something called KIT. And so this story I want to say is once those KIT mutations were found, people thought that in cancers like GI stromal tumor, where these inhibitors of KIT, these pills, can be very, very effective, investigators tried to say, it's like, oh, well, I've got this mucosal melanoma patient with a KIT mutation. Let's see if that pill works. And so these are a couple of pretty old case reports, right? These were just kind of anecdotes that were published that said, oh, look, we can see this 79-year-old patient, metastatic rectal melanoma with this KIT mutation. Let's see if Gleevec works, this KIT inhibitor. And you can see on the PET scan on the left, after 4 weeks of treatment, all those bright, hot, abnormal lesions have normalized, right? Showing that, in fact, that idea can work. These case reports are anecdotes, so they still have to be further tested. But these served as kind of proof of principle, supporting the launching of multiple prospective clinical trials. Now, unlike in more common cancers, the trials that were done were not randomized trials. These are fairly modest size, but multi-center trials of testing that idea. Does KIT inhibition work? And in fact, across these 3 trials, there was a response rate. We did see tumor activity. Didn't cure patients, but we did see some benefit in some patients. And then if you look at the amount of benefit for the patients who did have tumor shrinkage or disease control, they did seem to have a survival benefit. I don't want to go too much into the weeds, but along with the heterogeneity of rare cancers, along with the heterogeneity of kind of the molecular targets that we're doing, for some of these targets, like KIT targeting, there's a whole host, a whole range of different mutations, some of which are truly biologically important, some of which are just passenger mutations, some of which might be inhibited well by these pills, some which are not. And so as we think about this precision concept, I think we have to take that into account. And so if we look at Gleevec in KIT mutant melanoma, this seemed to work best in patients with certain mutations affecting these certain parts of the gene exon 11 and exon 13. Now in uveal melanoma, if you remember that pie chart, uveal melanoma, it was red. It was totally different than the other subtypes. And that's because the driving mutations, the driving alterations in uveal, completely different from the other melanoma subtypes. And so this is a disease that's driven by these kind of what I call G-alpha pathway mutations. And this is just a little cartoon showing kind of where that pathway kind of happens. But whether there's an underlying mutation in GNAQ or GNA11, all of those alterations end up activating a pathway called the MAP kinase pathway, which is on the right-hand side. And so this is work done in Gary's lab and so forth that showed that if we shut down that pathway with pills that inhibit, for instance, MEK, we could get anti-tumor effects. And so that led to a series of clinical trials trying to formally test that. Now in uveal melanoma as opposed to mucosal, we have been able to do randomized trials. And I think in part that's because the patient community is really, really tuned in to, I think, the science and where the trials are. There's a very active patient advocacy group, and the patient care seems to be centralized at just a handful of institutions. So we're actually able to capture those patients. These are 3 randomized trials looking at a MEK inhibitor called selumetinib. The top one is one that was sponsored by CTEP, the NCI. The second one was a registration intent trial that was international. And the third one, the CellPack trial, is one that was run in the UK. And kind of what can you see here? Both that CTEP trial as well as the CellPack trial actually met their primary endpoints, that there was some sort of benefit in those randomized trials. And if you look at the top, the benefit is in terms of disease control, that PFS number, it's there, but it was modest, right? 3.7 months versus 1.6 months. That CellPack trial also met its primary endpoint in terms of progression-free survival, 4.8 months versus actually 3.4 months. But the benefit's pretty modest, I have to say, right? No one's really writing home about that. If you look at the selumetinib alone, which is highlighted there in red, you can see some responses, progression-free survival on the order of 3 to 4 months. Seems better than chemo, which I highlight in the red text there, where there are no responses and progression-free survival is under 2 months. The best combination here seemed to be that selumetinib, that MEK inhibitor pill with Taxol, where you got a PFS of 4.8 months. But to be honest, I think the kind of almost discordant results we got here was I think frustrating to the field and the patients. It's like, what do we make of these data? So it does suggest that there's some benefit to MEK inhibition, but really, is that benefit clinically important? And then, if we're going to try to maximize that, how do we maximize that? So unclear question. One group, this is data from a company called IDEA, is looking at the combination of a MEK inhibitor with a PKC inhibitor that's kind of hitting 2 nodes of that GNAQ pathway. And they are seeing some interesting data. If you look on the right there, that's the waterfall plot. If the bar goes down, that means tumor shrinking. And you can see that we're getting some promising activity there. And so again, I think, the biology, it's sometimes tough in these rare cancers, even if you find a potentially actionable alteration. The question of how do you optimize that is a challenge. And sometimes it takes a long time, which is frustrating, I think, to patients. It's frustrating to us. And the question is how much do we invest in kind of one particular mechanism? Now, access to these therapies is driven by cancer guidelines. And in the rare melanoma field, we've been lucky enough to get MEK inhibition, this trametinib pill, in the NCCN guidelines after the initial selumetinib trials, right? Important because that means for our patients, who have extremely limited treatment options, if their doctor wants to do it, at least we can do it, okay? So that's really important. Same thing for cutaneous melanoma. We've got the KIT inhibitors in there as well. Okay, so there are options. And so a few key messages here. One, biology is critical. We have to figure that out. And to do that, we need access to high quality tumor specimens, ideally clinically annotated. Okay, to really figure that out, I think that we need this bottom line here. We need collaborative efforts, and that's collaborations between academic organizations, industry, patient advocacy groups. Okay, and I would say for all of our rare cancer trials, if we can get tumor specimens, blood samples, that's really critical, right? If we don't, it's almost a wasted opportunity. It's a burden on patients to say, it's like, oh, we want to do these biopsies, but it's the only way we're going to make this progress. So if you look at immunotherapy in these rare melanoma subtypes, this is a nice paper looking at Checkmate 172 was a 1,000-patient phase 2 clinical trial in patients with melanoma who had progressed on CTLA-4 inhibition. A paper by Paul Nathan. What he did was just look at survival by melanoma subtype. And in this kind of subgroup analysis, the outcomes in terms of survival seemed to be about the same for cutaneous and acral melanoma. But if you look at median overall survival for those with ocular and mucosal, it was less. Okay, so one of the questions is why might that be? Why doesn't immunotherapy work as well in these uncommon subtypes? For ocular melanoma, there's some kind of low-hanging fruit potential answers. We know that the more mutations present in the tumor, the higher the likelihood of immunotherapy working. And if you look at cutaneous melanoma, it has a high number of mutations on the x-axis and a high response rate to PD-1 inhibition. Whereas if you look at uveal melanoma, right, totally different. Very, very few mutations. In fact, one of the lowest mutation burdens of all cancers, and a very low response rate to checkpoint inhibition. We also know that response to PD-1 inhibition is associated with expression of PD-L1. And so if we look at uveal melanoma, we'll have the presence of this PD-L1 in maybe 5% of cases compared to maybe a quarter in cutaneous melanoma, right? So maybe those play a role. Certainly more complex than that, but maybe that plays a role. In mucosal melanoma, because single-agent immunotherapy with nivolumab didn't seem to work so well, it's been our practice for a long time to say, well, let's do more aggressive immunotherapy. Let's do combined Ipi-Nivo. Let's do combined checkpoint blockade. And part of that is because of work presented by Alex Shustari at Memorial, where he did a subset analysis of patients treated on a larger randomized melanoma trial called Checkmate 067, looked at the mucosal melanoma patients, and again, look at the numbers. We're talking about 28 patients who got Ipi-Nivo, 23 who got Nivo, 28 who got Ipi, so relatively low numbers. But if you look at the progression-free survival and overall survival curves, it was just better if you got combination. That's what that top curve shows, right? And it's pretty marked. 36% 5-year survival for combination versus 17% with PD-1. And so, this, I think, justified those of us who saw these patients saying, well, let's just be aggressive despite the toxicity. And then more recently, there was this wonderful effort that we participated in, but it was this international real-world kind of meta-analysis, 550 patients collected from 25 centers in Australia, Europe, the US, and Asia, looking at our mucosal melanoma patients and how they did to checkpoint blockade. The response rate, and this is to PD-1 or combination, overall response rate, overall rate of tumor shrinkage, about 30%, but no difference, 29% for PD-1, 31% for combination. And then if you look at the curves on the right, those are the progression-free survival and overall survival curves of single-agent PD-1 versus combination. There's no difference, right? So we've got that, we've got this real-world data experience, and we've got that prior subgroup analysis from a prospective trial that show conflicting things. And so clinically, what does that mean? Which one's right, and to be honest, I'm not sure. I tend to say the real world data is right. So key messages here: a large retrospective and prospective data sets with highly granular data are really important information sources for our rare melanomas. I think the conflicting data we see from these subset analyses from prospective trials and the real world data sets pose some challenges and hopefully some opportunities to figure out why that is. And I guess I'll talk a little bit more about this in a bit, but as we think about the use of real world data in cancer, how do we use that for drug development to facilitate things? The presence of specific guidance from regulatory authorities certainly would be helpful. So if we look at melanoma subtype by race, I've got melanoma subtypes in the Caucasian population on the right here, and you can see the vast majority of it is cutaneous, as we kind of discussed. But if you look at the melanoma subtypes that we see in China, it's markedly different, right? Where only a quarter of cases in China are cutaneous, about 50% are acral, about 25% are mucosal. And for that reason, as you might imagine, all of the big trials, and this is it, all 5 of the big trials that were done in mucosal melanoma were all done in Asia, 4 of them done in China, from one center, to be honest. Because of the concentration of care, right, all the mucosal melanoma patients really just go to the same center there. They were actually able to do these randomized trials. I can say in the U.S., we've been and through the Alliance, we've been talking about trying to do mucosal melanoma trials here, and there's still efforts. There are trials ongoing. We haven't been able to do anything like this yet in the U.S., right? And I think that kind of highlights how we have to think about where are we doing the trials, where are we going to get the patients, what questions can we answer, in the mucosal melanoma patient population. What I highlight in red here is that 2 of these randomized trials actually looked at adjuvant therapy. That is, after patients with mucosal melanoma undergo resection and we're worried there's a high risk of this coming back, if we give them chemo or if we give them interferon, how do they do? And both of these trials showed that if we do chemotherapy, the patients do better than if we observe them or give them interferon. So we have 2 randomized trials showing that, both from China. What was interesting is we're working with the Melanoma Research Foundation now to put together kind of guidelines or kind of a white paper about mucosal melanoma. And as part of that effort, we sent a poll out to nearly 50 melanoma experts around the world who see mucosal melanoma, and we asked, do you agree with this recommendation? Should we discuss adjuvant chemotherapy in patients with resected mucosal melanoma? And I was a little bit surprised that it was a total split. Half of the experts said, yeah, we should talk about it. We've got randomized data. Half the experts said, nah, don't really believe it. I don't know what to, it's just interesting, right? And so when we're talking about these rare cancers with kind of relatively small data sets, trials done in different countries with different ethnic, racial populations, how as a field are we going to interpret these data, and are we going to actually use it? So kind of striking to me. In uveal melanoma, we've been more successful in the US and in Europe in doing randomized trials. So these are all the randomized trials we've done in uveal melanoma since 2000. Half of these in black are phase 2 trials. Half of these are in red are actually randomized phase 3 trials, which I think is pretty important in the field. All of these trials were actually completed except for 2, right? Which to me suggests that if we design the trials right, completion of these rare cancer randomized trials in uveal, it's actually feasible. The top 3 are the most recent of the randomized trials, and you can see that as opposed to the trials below where the control arm were things like chemotherapy or even observation, the top 3 all randomized patients to the study treatment versus best alternative care, and that just raises the question of how are we actually going to get patients to agree to going on these trials. And one of the struggles as we started developing these later randomized trials was patients wanted checkpoint inhibition. Even if I said checkpoint inhibition probably is not going to work, they weren't going to go on a trial if it wasn't an option. And so these more recent randomized trials included investigator choice, chemo, checkpoint blockade, PD-1, or so forth. The last trial, that one by Nathan et al., looked at a drug called tebentafusp, which was the first drug to be approved for patients with uveal melanoma. And this was approved based off of 2 trials, a phase 2 single-arm clinical trial with a primary endpoint of response rate, and then a more standard randomized phase 3 trial. And that phase 3 trial showed that there was a significant improvement in terms of overall survival. Hazard ratio for survival, 0.51, so nearly a 50% reduction in the risk of death if you got that tebentafusp. And so this was certainly practice changing, approved in the US in January, approved in Europe in April. And so, key messages, I do think the feasibility of trial conduct, it's dependent upon the subtype of cancer we're dealing with, as well as kind of where we're thinking about doing the trials. We can rapidly accrue to some rare melanoma trials like uveal. Mucosal is just different. It's very heterogeneous in terms of the types of patients who develop that disease, the doctors they see, and where it occurs. And just one recommendation that I'd love to make is that the patient acceptance of trial design has to be considered as we put these trials together. Otherwise, we're just not going to accrue. So this is kind of the last bit. In the uveal melanoma field, we've really tried to learn as much as possible, not just from the prospective clinical trials, but from completed trials, retrospective analyses, and so forth. And so through this group called the International Rare Cancer Initiative, we did a single patient meta-analysis looking at patients put on one of 29 clinical trials of uveal melanoma over about 20 years, and just looked at outcomes, right? Not randomized, but what we wanted to do was create benchmarks so that if we were doing a small single-arm trial of, for instance, chemotherapy, what would be a promising response, right? And you need that if you're not going to do a randomized trial. And so we created these benchmarks for outcomes for systemic therapies and for liver-directed therapies. But there are very few patients treated with immunotherapy here, which is really kind of what I think the standard benchmark now would be, or at least pre-tebentafusp. And so now we've got another prospective natural history study called OMNI, the International Ocular Melanoma Natural History Study, which is aimed to track the natural history as well as treatment course of patients with uveal melanoma across centers around the world, including the US, the UK, Australia. We have sites in Canada and Germany coming online as well. So I think these sorts of efforts really have to be done in all rare cancers. I think it's complementary. I think it can help facilitate drug development. How can we do that? Well, one, we can use these data that we're collecting to create what we call these synthetic control arms, again, to try to help us understand, is the outcome good or not? And this is just a paper of a single-arm adjuvant trial of crizotinib in high-risk uveal melanoma. And we wanted to see, can this treatment reduce the risk of the cancer coming back? It's not randomized, right? And so on the curve, we saw the clinical trial curve, which is that green-blue color. About 50% of patients recurred at 36 months. How can we tell, is that good or not? We did a synthetic control arm. Patients matched for clinical characteristics and risk, and that's the red, it totally overlapped, right? And so that gives us confidence that, unfortunately, this drug did not work. And no one real-world data set is sufficient, and so there are multiple other groups doing kind of parallel efforts, one by the Melanoma Research Foundation called VISION, where they're collecting data directly from patients. So it's a patient-driven, patient-reported outcome data set. The Melanoma Research Alliance is doing a patient-reported effort for acral melanoma and for mucosal melanoma. And thankfully, we're all talking to each other. So even though these are parallel efforts, I think we can leverage the data we're collecting from each of these. And so I'm just going to close with, again, highlighting the various groups working on patient advocacy for rare melanoma. I think patient advocacy is absolutely, absolutely critical in helping us move the field forward. And I'll just say, last recommendation, joint efforts between academic institutions, pharma, patient advocacy really has to be promoted as we try to advance the fields.